My name is Safwan Halaby. I'm from Henry Ford Hospital. I'm a radiologist and director of imaging informatics. This session is going to be dedicated to the decision support and appropriateness criteria. The essential thing here is I've tried to get speakers that have lived, breathed, and actually implemented decision support in their health systems. What we have is the appropriateness criteria. Many of you know it's a static document that lives on the web of peer groups that have come together and decided these are the right exams to do at these particular times. And so what we're seeing the transformation is taking that static document and making it a digestible, living, breathing entity that people can imbibe and use at their health systems for the purpose of care and for the purpose of patient care. Now, there's a lot of nuance behind it regarding payers and health systems and government, and we'll try to touch on some of those things. And we'll also update you on the Medicare imaging demonstration project. Any questions that you have throughout any of the panelists or the talks, you can please go ahead and text that phone number that's on the screen, and I will try to present those questions to the panelists. And first, I'd like to introduce Ms. Kelly Vinz. She is the excuse me, one sec. She is the Vice President for Healthcare Improvement and Member Relations at the Institute for Clinical Systems Improvement. She provides leadership and oversight for the Scientific Document Program and is involved with the membership and improvement initiatives with ICSI. She's also provided leadership oversight of high-tech diagnostic imaging decision support for the past 6 years. And she's basically gone across the country consulting different health systems regarding these initiatives. So I'd like to introduce Kelly.
I gotta move this down, I'm short. Let's see. Basically, I know we're a little short on time, but I want to make sure that I can touch on the things that I think might be important that you would want to hear about. I can talk about this for a whole day or 15 minutes, so we'll get it to 15 minutes. First I want to tell you a little bit about ICSI because it matters because of the environment we're in. We are a healthcare collaborative of payers, so the health plans in Minnesota pay us to do our work, and the healthcare providers in our state pay us to do our work. We bring healthcare organizations and health plans, employers, and patients together to collectively do healthcare reform in a way that, particularly complex problems, in a way that they can't do independently or individually. We have over 9,000 physicians. We have, in providers, it's in the tens of thousands when we reach out. We have organizations that are as large as Mayo Clinic and as small as a one-physician organization way up on the northern borders of Minnesota and Canada. So we've got the breadth, we've got primary care, we've got specialty care. We have organizations like CDI, which is an independent radiology provider, and then large integrated systems and specialties, orthopedic specialists, OBGYN specialists. So very, very broad spectrum of organizations. In Minnesota, like everywhere else, back in the early 2000s, imaging rates, utilization rates were skyrocketing, and we were trying to figure out what we were going to do in Minnesota, and the health plan's first solution was go to a radiology benefit management system, put in prior authorization, prior notification, and that'll do it. So as soon as they started talking about that, the medical groups came to us and they said, and I'm not even going to pay attention to that. I'm just going to tell you the story. The medical groups said, no, we can't do that. We've been down that path before. Let's not go down that path again. So we came together with health plans, medical groups, radiology providers, and said, what are we going to do? Let's look for some options. Clearly, decision support was high on the list of options. So when we put the group together, the goal was to find an alternative that you could use in an EMR, one that can be used in a web-based solution that uses evidence-based appropriateness criteria, that we can add evidence-based to it as we move forward, that over the long haul we can keep contributing to the improvement of the appropriateness criteria. So that's what we did. We also wanted to leverage the EMR investment, because in Minnesota, about 70 to 80% of the providers, it's the highest in the country actually, the Department of Human Services did a study, and we have the highest EHR integration in the US. And so definitely most places wanted to have an EHR applicable intervention. So we launched a pilot, and at first we sat together, and because we have so much EHR, all they kept saying is, don't give us a bolt-on system. We don't want to maintain a link. Don't give us that. So they started developing appropriateness criteria using ACR, bringing together specialists and taking the ACR criteria and trying to create a decision support process. And they integrated it into Epic. I remember sitting at meetings clearly knowing that I was the lowest paid person in the room. And I mean, we were spending thousands of dollars per meeting just to develop one little set of criteria. And I mean, we could spend hours and hours doing it. So I kept saying, I don't think this is sustainable. I don't think this is sustainable. But they developed it. And as we developed it, they gave it to anybody that had an Epic EMR. So we gave it away to everybody in the state, and it worked out really well. And we started to see a change in the utilization rates. When we did that, we did over 1 million scans. Oh, well, and actually I have to say, one of the organizations was not very far along in their Epic integration, so they actually went out and bought it from a vendor service. So we had different experiences going on there too, which was really helpful in our evaluation. We ended up doing over 1 million scans during this pilot. We had 6,000 providers, or nearly 6,000 providers, using it, and we only had 5 systems using it. So we had a good experience. We knew what the outcomes were from it. We studied the data, and the results were that we pretty much flattened the utilization curve. This is the data from, well, this was up to 2010. Later in the presentation, I actually have the most recent because I just got it yesterday. But we flattened the utilization curve. The red line is where it would have continued to go, and you know, and I've had lots of discussions with RBMs telling us that we're the ones that flattened the curve, and you can't take credit for that. And I said, I don't care who flattened it. We found a way to sustain that flattened utilization rate in a very provider-supportive, patient-centric model that is less expensive. So, you know, for us, this was a much better solution. So one thing that we did learn is that when you didn't use licensed appropriateness criteria, so the stuff we developed, we got in that 65% high utility range, and we had a lot in the about 25% in the bucket of other. We don't know, we don't have, you know, we had a lot of other. But when we used purchased utilization or appropriateness criteria, we really got better utility scores. So, and that has continued as we've moved forward. So what it told us is, okay, it's too expensive to try to maintain this criteria ourselves. Let's go find a vendored solution. Clearly, we're getting better results with the vendored solution. So that's when we went out and we sought all the vendors, and we did an RFP. And for what we chose in Minnesota, we chose one vendor, and it worked really well. We started to integrate that into all the Epic sites and provide a web-based solution. At this point, we are in over 110 organizations. And when I say organizations, that can be an organization that has 80 clinics, that's one, or an organization that has one office. So I have never counted all the clinics, but it's large organizations, mostly in Minnesota, of integrated systems. Another value in the measures, I just want to track back a little bit, another value that we had is the time savings. When we were doing this pilot, one of the organizations did a time study for us to count how much time it took to do an RBM and how much time it took to do decision support. And they saved about 2 FTE, and this was one of our smaller integrated systems. So I know that our largest integrated system, they did an estimation, and they were saving from 5 to 10 FTE, not calling the RBMs. I mean, normally in that case, it's not physicians, it's other staff, but it's still a cost to the organization. We estimated over the 3-year pilot that we did before we started rolling it out all over that, and the reason, the pilot was intended to last a year, but they wouldn't let go of it, so we actually kept it on for 3 years while we were working on the integration with our vendored solution. But we saved over $84 million from what we would have spent to what we actually spent. That was our estimation. We saved a lot of hours, 11,000 hours we estimated in staff time. And we also contributed to a decrease in radiation-exposed cancer, or radiation exposure caused cancers. And we didn't, I know there's a lot of controversy about how much that is, so we just said we contributed to that. But we spread the pilot then. We are now in over 110 organizations, and we find that we have a very provider-supportive, patient-centered approach. And I want to describe a little bit, because I was talking at the table I was sitting at, and everyone always is very interested in this. The solution, we support using it with the patient and the provider in the exam room, with the computer right there, the screen right there. They enter it in as they order. They do it. It takes 10 seconds, and I know we get how many clicks it counts and all that. We have heard all of it. But we support that because then the provider can talk with the patient about the plan, the decisions that are being made, get engagement with the patient, do shared decision making, and the patient is so much more likely then to follow the plan of care that you've established. They don't ever leave in any of the sites, whether it's being done in the exam room right with the patient, or if it's being done at a call center, or if it's being done by the CMA out at the front desk. None of the patients leave the organization without knowing exactly what exam they're going to have, and that it was highly recommended not only from their provider but also from the evidence-based decision support process that their providers have used. And you might ask, being a room full of or a lot of radiologists, why would we like this? And the radiologists in our integrated systems and the independent radiologists have supported this the entire way, sat on the steering committee, and been our strongest cheerleaders. And what they describe to us is that when I'm able to have those in my organization or those that I consult for use decision support for the routine, for the most of their imaging, it leaves me the opportunity to do consultation with those complex cases, those times when the provider just simply doesn't know, or the evidence is so weak it can't guide you in the right direction. So it really, really is been really strongly embraced by the radiology providers. And for those that are independent radiology providers, they have offered it as one of the options that they can do for those 1 and 2 doc shops that are, not quite ready to move into EMRs and not quite ready to do that kind of work inside their own organization. So we see this being able to be used, decision support being able to be used with the patient and the provider in the exam room, all the way along the continuum to the order comes to the radiology or rendering provider organization, and they do the decision support. Now, if it's happening outside of the exam room, what we've worked with our organizations to create is this workflow that gets that answer back to the clinic before the patient leaves the clinic, because what we wanted as part of our goals was that it was patient-centered, and it's not patient-centered to walk out of a clinic not knowing, number one, if the exam is approved, not knowing if it was the right one, not having any idea when it's scheduled, or worse yet, thinking you know those things, and then getting to the rendering provider at the time that you're supposed to have your CT or MRI or whatever, and being told, oh, sorry, I know you took a half day off, but we can't do it today because it wasn't approved, or it's not the right exam for you, and now we have to start over again. That does not breed trust and confidence in the patient-provider relationship. So we wanted to get away from that. We also really supported having the decision support done at the point of order because of that iterative education that happens. That iterative education is something that the providers have really valued. And you would think their ego would get in the way and they would not like that, but instead their competitiveness got in the way, and they really wanted to be on the top of the rung of the data instead of on the bottom. And so they really liked that immediate feedback, and they really appreciated to be able to know that I'm not out of sync, I'm not an outlier with the rest of those that are providing care in my organization or even across the state. So it's been really valuable. Flexibility is, with lessons learned from as we've done this whole project, the one thing that we have learned is flexibility is key. It's key to have an alternative that's an EMR integrated option. It's key to have one that's a web-based option. It's key to be able to have workflows that work inside the exam room and that work in a call center and that work all the way into a rendering provider radiology center. I mean, you have to have workflows that work in all places because providers need to be able to have that option. Organizations need that option. In our work, the cost was supported by the health plans because they were the ones that were putting the requirement for the RBM or prior authorization. And so instead of doing that, we put in this alternative, which was much less expensive by a tenth of the cost. But we also have learned, as we've done it over the last 6 years, that we actually need flexibility to have the cost being borne by any stakeholder. It can be employers. I've consulted where employers are supporting the cost, where radiology groups are supporting the cost, where health plans, and then in Minnesota, it's transitioning now that actually the organizations are supporting the cost of the decision support, because when they're in a risk-shared ACO environment and those kinds of contracts, this is one of their strategies to mitigate for rising costs. And so they're taking on the cost of decision support. So we've been seeing some transition over the years because there's a lot of ACO risk-shared contracts that are being established in Minnesota. Another lesson that we've learned is that we need a common set of appropriateness criteria. And I remember when we first started this, I came begging to ACR, is there a way that you can have your criteria in a different format that was more friendly to decision support? And I'm thrilled that's where it's gone, because that provides us with a common set of appropriateness criteria that they can use everywhere. And I'm hoping that we can develop a way to provide feedback, and because that really creates a sense of confidence from the user's perspective. So we're really thrilled about that. The medical groups and the payers in Minnesota are very excited and have really embraced the ACR criteria being put into a product that can be used directly. And then the other thing that we have learned is that data is really important. We have to have a way to be able to see what are our aggregate utilization rates. Is it getting better? Is it getting worse? Just good old-fashioned quality improvement. But we also have to be able to say, in your organization as orthopods, how do you compare to each other? How do you compare to others across Minnesota or across the country as family practitioners. We really see that as very important also. The piece that we would really like to go to is to start to link the appropriateness or utility of an exam and the outcome for the patient, and not linking it to what are the findings, but what the true outcome of the patient is. And we were actually headed in that direction when the changes with the vendors started to happen. So we've got a great study that we'd like to do, but we need to wait a little bit, where we start to link patient outcomes to utility scores of exams and start to make those combinations. So I think I'll stop there. Currently, I guess I need to tell you that. Currently, because of the change in the Nuance product, and they are no longer going to support the Radport tool that we were using, we're actually sort of waiting for the ACR Select to come out. We're going to do some transitions. Organizations are more taking some of the role. The health plans haven't stepped away, but I'm seeing that more because some of the contract measurements, quality measurements, are utilization rates. So we're seeing some changes there. And then we're also looking at trying to find ways to provide feedback. So that's where we're going. And this is our most recent data, hot off the press. So this is 6 years worth of data I think we've got here now, or no longer than that. But you can see we had a little spike. We had a little problem with one of the health plans' data, so we can't tell yet. We're digging into it whether that spike at the very end is due to some bad data or if we just had a spike. But we were happy to see that it came back down again, and we will continue to monitor this. This aggregate utilization. So this is all of the health plans in Minnesota that have these are, and the Department of Human Services are giving us this data to have aggregate claims data on how many exams are being done. We also have it broken down with MRIs and CTs and that. But I think I'll stop there then, and we can address questions later. Don't text me.